interested in fitness, in wellness, and overwhelmingly, who's winning in the wearables market right now? It's Nike with embedded technology in shoes. It's Fitbit with their fitness-oriented technologies on the wrist. But there's some interesting newcomers in the market, all right? Apple and what they're doing with the watch and their partnership with Google and some others, and a whole nother range of devices. And I do think that we have consumer devices, we have devices that are probably best left in the hands of professionals, but we have this tremendous need to take this great technology and figure out how we move it from the healthiest, most affluent participants in our market to the poorest, sickest participants in our market. And I think that really is something we're going to come back to over and over again. I wanted to start, though, just by giving our panelists each a minute to just kind of talk about, so what part of this wearables market or industry or technology are they engaged with, and what are they focused on?
So like I said, I am a cardiologist, so I've been implanting pacers and defibrillators for a little over 20 years. And they really started off more as shock boxes and paces. They were not meant to monitor the patient. But as most of you know, that has really changed over the last 5 or 10 years. Whether it's Medtronic's Optivol, where they actually can monitor your fluid status and see if you're going into congestive heart failure, to St. Jude's CardioMEMS, an implantable device in the pulmonary artery which can monitor respiratory impedance and tell you whether you're going into heart failure. And these devices have actually been shown to decrease heart failure readmissions and hospitalizations, all the way to the new devices that are coming out that are less invasive. So there's Medtronic's new injectable pacemaker, leadless pacemaker, where they can actually inject a pacemaker about the size of a pebble inside your heart, and it can pace your heart. All these devices are meant to treat, but are also starting to monitor patients and help us keep them out of the hospital. And so, yeah, that's great. We got new things. We got new data. How do we use this data? Who is seeing the data? How do we collect the data? Am I able, as a cardiologist, and by the way, I'm also a CMO, so how I do all this, how do I take that data? Do I have time to see it every day? I have over 100 patients with defibrillators and pacemakers that have Optivol or patients with CardioMEMS. Who's seeing the data? How are we monitoring it? And how are we using it to do what they're meant to do and what they showed in the studies? How do we keep them out of the hospital, and how do we keep them from being readmitted? This is and everybody kind of does it different. Do we hire nurse practitioners to look at the data? Do the doctors actually look at the data? Do we have pacemaker clinics that actually have expertise in them, and they can call us or email us or text us when they see a patient, because they're getting this data real time. The Optivol, the CardioMEMS, this is real time data. Are we real time monitoring it?
Right.
So this is something that a lot of people are struggling with, but we have to determine how we're going to do that in the future.
So hello, I'm Eileen Jaskuta, and we are really exploring this really with our employee population at this point in time, because we're self-funded, so we're trying to see ways to incent employees to be healthier, and we do know that we have employees that are at risk for hypertension, obesity, and other areas. And so we're trying to encourage them to use the wearable devices for health and wellness points as a reduction on their premium. And so that's where we're going to start this journey. But I'm also very active with outpatient care management, and we're trying to figure out ways that we can utilize this in our practices with our patients and have the outpatient care managers actually look at that data and help alert the physicians around that. We haven't necessarily deployed that yet, but we are looking at that. I'm in Maryland, so we have a little bit of a different payment structure, and they are starting to look at incenting us and giving us dollars for some of the infrastructure development in the outpatient arena. And so we're trying to see if that's how we can utilize some of that funding.
So great. So we at Cedars-Sinai had a collaboration with Apple and HealthKit, and we actually opened up our patient portal to anyone that had an account for them to upload their devices and connect their devices. So my watch sends my data every 15 minutes to my account, and I can view it on my smartphone and see what I've done for the last month. I think, again, we talk about the volumes of data and how to actually utilize that. We've created a dashboard with a Tableau type application that allows for the provider to look at it in a more meaningful manner instead of just flow sheet row after flow sheet row, pulling out maximum, minimums, different types of variation on that in order to try to help make some sense out of the data. I want to echo that we see this as understanding how we can get the platform right, because then we can start talking about how we can utilize it in populations that we want to really manage, like the ones that are more complex and have multiple different areas that we need to begin to view. We've tried a pilot with scales and blood pressure cuffs for our sickest congestive heart failure folk discharges from the hospital, and that's been slow to take off, in part because the care is already very complex. Right. These automated hovering devices do that. They hover, but they don't really change care, right? You have to have somebody still act on it, so they're not smart enough to do that on their own. And so I think we have that overlays with the behavioral modification that may need to happen. And there's some interesting work that's coming out from University of Pennsylvania, Dr. Matish Patel, who presents his work on what motivates people and folks to actually lose weight or stop smoking and those type of things. And it's actually, in a study that he published in February looking at obesity, it was really the group that got paid the $42 up front and had to give back $1.40 a day for every day they didn't reach their 7,000 steps. Those people had a 50% success rate as opposed to like the low 20s for the control group, the people who got the money up front or were entered into a lottery. So when we start understanding what that looks like, do we, prepay their premiums for the year, and then for every month that they don't meet their goal, they have to pay us back that month's premiums. I mean, we have to begin to look at those factors, either as employees or wellness or some of those other pieces.
No, it's interesting that you bring that up, because gamification and wearables is something that we always talk about together, and again, we see this over and over. And maybe we'll come back to that in a minute, but I think, one of the bigger issues is the issue you bring up, that we're going to drown in data. All right, so we put a couple million devices in the market, and those devices generate a couple gig of data a month each. All right, and now we're looking at terabytes of data that really is of uncertain value. And again, we get back to, is there any value in maintaining a normal EKG, or could we just set a bit that says, the algorithm says that nothing exceptional happened, now we're going to consume 1 bit instead of 500 megabytes, and we'll move on. And we have to begin to think about, how do we manage the data? As you guys both brought up, everyone's brought up this idea that docs can't just sit here and look at this. Right. So have you thought about that? I mean, I'm assuming that you're targeting some kind of analytics environment right off the start is the place where you're going to put this data?
So what we did was, we didn't actually try to collect all of the data. We said, what is costing our system the most money? It's the patients that come to the emergency room the most. So somebody was talking earlier about they had a patient who had come 300 times in 2 years to the emergency room. So why not take the patients who used your emergency room the most for a heart failure, let's say, and use that data to try to affect their behavior, that is coming back to the emergency room. So what can we do? Whether it's a scale at their house, whether it's monitoring their Optival or whatever on their CardioMEMS on a regular basis to try to keep them out. Actually use the data for the patients that are using your healthcare services the most. And I think that's one way of doing it. That is, don't necessarily try to attack the whole thing. Attack the small part that you think you can make a difference in. And I think it's those patients who are using the most services, or need the most help, or are underserved, don't have insurance. Those patients that need the help. That's where I think this might best be used. So.
Yeah, and I do think that we should distinguish between the FDA-approved devices and the fitness monitors.
Right.
But that line is blurring,
Right.
and so if we're going to start sending people home with a Philips monitoring strip that sends back a week's worth, be good for a week after discharge, that could be very valuable.
Right.
But somebody has to still look at the data. The algorithms, if people come up with the algorithms to what's meaningful from some of this, it's going to be incredible. And I'm sure that there's lots of, like you say, analytics folks working on it. Sure. But knowing when to act is still generally a human factor.
It is.
Right.
And I think that's what's hard to know, even with, say, employees that have
Yes.
good health literacy.
It is.
Yeah, and it is interesting, there are several providers working, right now on commercializing cardiac algorithms for this kind of an environment. And, we do think one of the challenges you have when you're drowning in data is you have to figure out a way to make the analytics actionable. All right, this can't be something someone has to feed through, flip through. We have to create some kind of algorithmic or systemic way to identify these problems, and that would mean that we've actually integrated the device into a care plan. This isn't kind of an afterthought. We've actually built the plan around the availability of the device. How is that happening already? Is that something in our near-term future? Is it further out?
I think so. I think we're trying. I think everybody's approaching it a little bit differently. Whether it's when you get the data, can you get to that patient that day and say, give some Lasix IV to keep them out of your emergency room, keep them out of your clinic, so that you have access. I think we're trying to develop algorithms, and I'm sure different people use, for instance, at our hospital, we're using so-called dyad approach, where we have a physician, a nurse, and an administrator working together as a unit on different diagnoses, DRGs, whether it's heart failure, stroke, sepsis, to see how we can take this data and apply it to our patients and improve their health. So.
Yeah, and I would say that, I think that there's a lot of new technology for medication adherence,
Right.
like the ingestibles that signal when you're send off a signal when it's ingested. What I will say is that that's also the monitoring, say for a $20,000 chemo regimen, that may be worth doing the compounding and putting those chips in there for each one of those to make sure each one of those pills is taken.
Right.
But Open Notes, familiar with Open Notes, right? Where Open Notes has the same level of compliance with medication adherence as does some of the studies with ingestibles.
Right.
So there's medium tech, non-monitoring, but then there's the monitoring, and I don't know. I think we have to understand which lane or which avenue, which what we want to implement for what we want to get out of it. And I don't know we have enough success stories yet, right? About whether we want to monitor everybody or just the people that have already failed once.
And they've done studies to look at what really keeps, for instance, a heart failure patient out of the hospital. Is it the fact that they have a device? Is it really it's the fact that they saw their doctor or a provider within a week? And that's really the only thing. And you can collect the data and get that data, but if they don't have a transition of care when they come out of the hospital, that's then they could be readmitted.
Right. So when we look, broadly at the market, we look at consumers, and there's a fitness and a health component to that. Then we look at devices really used by a physician in a plan. Then we look at things an employer might do with their employees. And then we look at the elderly, the whole aging in place, and how do we help them. So, kind of four really different markets here, kind of under one umbrella. Employees, I think, is a really interesting one because it's one that is already happening. A number of the large payers have already introduced programs like this. I hope I'm not speaking out of school. If you go to Aetna's, campus in Connecticut, you'll find that the gym is on the ID and the fit lunch. All right, there are two or really more than two. They have a wonderful cafeteria, but there's literally a healthy line in the cafeteria, and you get credit if you buy the healthy lunch. You get credit if you go to the gym. I mean, they've done a great job of integrating campus behavior into their wellness plan. And so I wanted to come back to that a little and say, so from an employee perspective, I mean, what are your kind of hopes and where are you focusing?
So we're really focusing right now on those employees that want to be engaged. So
Yep.
some of those people that are probably already fit and already engaged and working out in the gym and things like that. So we're focusing on those individuals, and right now we're having them work through health coaches in order to get their data and to work with their data, and for those people that are having struggles, to have somebody on the other end to help them facilitate what they need to do next. And it's really an experiment right now to see
Right.
how it works for us, but we are starting to see that our employees are becoming more engaged. And last year, we discussed it, and we told people that they would do better with their points and their premiums if they participated, and the participation wasn't great. This year now we're starting to see people really understand that it really does matter. So we are seeing more and more employees, and it's not only the employees, it's also their families. So if their families are covered by us, there's an expectation that they're participating as well. So we're starting to see some traction around that.
Do you think that's because of the money?
I do think it's because of the money.
It
So
always
who
is.
pays? Who pays is important.
Yes.
So let's talk about that for a minute. Who should pay? All right, I mean, our data suggests that if you go and buy one of these in Best Buy, you go buy a Fitbit in Best Buy, 75 to 80% chance it's in the back of a drawer in 90 days or less. And we've done that study a number of times, and that is the abandonment rate of that technology among the general public. A physician asks you to use the technology, that number turns around. 80% of those patients do what they're told. So the physician has to build it in the plan, but does that mean it needs to be reimbursed? And who should carry the cost of this?
So right now, what we're doing is something called Healthy Lives with our employees, actually. And what we do is we give them a break on their health insurance.
Yep.
So if you reach some goals, whether it's your cholesterol, weight, blood sugar, whatever, we're actually going to take money off of what you pay for health insurance.
Right.
And so so it is a financial sort of reward, and I think that's what works. Sometimes, in some cases, in Louisiana, our employees are less healthy than our patients. And so we have a direct incentive to try to improve our employees' health to keep them around. And so,
Never look for new markets.
Every market is different. Politics is local. I think incentivizing your employees to do this is, and so in some cases, I think it's the employer that really should consider paying for it, depending on your
Correct.
situation, right?
Correct. But then when we talk about the other populations that we're trying to serve in the population health model, that's
Right.
where I think the struggle is on
Yep.
who pays, right?
Right.
Because when they're employed, that's a different story. But when you have people out there that are safety net and need sort of to be cared, they're the underserved, then who pays? And I think in some respects, at least for us in our model in Maryland, I think if there is some funding for the infrastructure and the outpatient, that maybe you utilize that for those individuals that really can't manage on their own and sort of incent them that way, utilizing that to try and increase their wellness.
So we're part of the comprehensive joint replacement bundle. Yay. In Los Angeles. And interesting though that there is money in that particular package that you can actually provide to the patient. Money you can buy and provide things for them. So we could actually provide, activity trackers, or we could provide a tablet for them to communicate with us, etc. So there are some limitations to that, but I mean, I think that, new models of care, traditional CMS, you couldn't put it on any
Right.
type of bill.
Correct.
You're
Right.
not going to dispense it as a prosthesis or anything.
Right.
But, the reality is I think that there may be some, innovative places, and if you're at risk in the population health world, any money that you spend that does prevention really ultimately probably has an ROI on it if you can
Correct.
figure out how to manage it.
Right.
So we're involved in 2 bundle programs. We're in the joint bundle, and we're also in cabbage bundle. In our joint bundle, our orthopedists have taken risk. They're making money. In our bypass bundle, the heart surgeons decided not to take risk. They're losing money. And the question is, well, first of all, we got to get them to take risk, and so that's part of it. But also, it's what can we do to, so where we're losing the money is really post-acute care. A lot of home health use and kind of readmission problems. What can we do from a wearable, connectable, to keep those patients out? And I think it's heavily involved in the bundle program. What money can you put into it to save money on the backside?
Right. We're looking at care communications through a web application that's integrated into the portal, and looking at care communications around, asking a series of questions for specific disease processes, like, have you noticed any change in your breathing pattern? Mm-hmm. Yes, no, and then those are targeted up and compiled for a case manager to review and to make calls and intervene. So I think that, again, we don't know what's going to work the best, but we're beginning to look at some of those type of care communications post-discharge, because people processes are really hard. It's really hard to have home health. If your target is to save $700 for a large group of patients per patient over the bundle, I mean, it doesn't take a lot of home health to
chew that up.
To do that up,
right.
Yeah.
right? Or I know acute rehab, yes, I know that. We're out of any bundles because of the sheer cost of that. But the reality is that I think that we have to look at ways of doing things differently.
Right.
And if you're starting population health, which many of us are, not the bundles is sort of a microcosm, but once you start a large, hundreds of thousands of lives, how do you apply this technology to save money there as well? I think it's important.
So, and certainly population health is where a lot of the early interest is going to be. I think, this is an area where we'll see technology over 10 or 20 years, where I think 15, 20 years from now, a parent is going to decide at birth whether they want, in-body monitoring, as an option on their infant. We can take care of that just like we can do some of these other things during the OB process. I think Godfrey Cambridge made a movie in the 60s called The President's Analyst that talked about injectable monitoring at birth. Only AT&T was going to do it. It really is. I mean, it's a fascinating set of technologies, but it brings all the other issues that other technologies bring with it. All right, if this is a wearable, how do I know you're wearing it? All right, if I'm an employer and I'm paying you to be healthy, how do I know it's you being healthy? How do I know you're not telling your 17-year-old that they have to do this as part of what they do to get their allowance? You want a good laugh, go look at YouTube about how to beat your Fitbit, and you'll find half a dozen ways to generate 10,000 steps in 5 minutes or less with common hand tools and a Fitbit. All right, put it on a tennis ball, spin the tennis ball on a drill, in 45 seconds you've walked 10,000 steps. It's staggering. So is that an issue for you guys? I mean, how do we think about data integrity here? I mean, something comes in over the wire. How do we know it's what we think it is? Is that a device maker issue? Is that a provider issue? Who's going to tackle that part of the problem?
Wow.
Good patient contracts. Good patient relation, patient-provider communication and engagement for integrity of the data. I mean,
yeah.
It's a risk. We don't know that, their daughter or son might not step on the scale and it'll give us an inappropriate reading perhaps, but I doubt very few people are going to prick their fingers, and upload it. So that may be a different level of data integrity. But I do think that it really, we have to understand the limitations of what is incoming. Now, you've implanted it, hopefully.
You know.
I like to think it's there, Dave.
I think you are the safest in this group. But I think it's true. I'm not sure what the answer is.
Well, no, because there's a sliding scale, right? I always lie to my mother about my health. I might lie to my employer about my health. I try hard not to lie to my doctor about my health. You're absolutely right. But now, I'm kind of in all three groups, right? All right, we're going to, through population health, we're going to engage the family. We're now going to be, through social media, we're going to be a group, right? we're all going to care for these people that we lie to about our health every day. All right? So, and then maybe an employer is going to pay us, and I might lie to an employer. I don't think I'm going to suffer a mortal sin over that. All right, but I try to be truthful with my doc. So hopefully, if I'm reporting my own results, but I do think that employer market is going to be an interesting gray zone, and certainly if you manage staff, you know what they're capable of.
Maybe the e-futurist knows what's going to happen.
Yeah, it's drone surveillance. It's going to solve the problem through constant.
Well,
Maybe Google ubiquitous monitoring, but you could have buddy verification too.
Right.
The
Well,
Internet of Things is everywhere.
yeah, the drone on my shoulder is going to do my food diary for me, right? Yeah. Oh no, he ate that. Not what he said. He ate that.
So it's a whole new field, but I usually trust that the blood work actually came from the patient, that the
right.
defibrillator data came from that patient, the pacemaker data, all that. But did the Fitbit data come from that patient?
Right.
Did the wearable data come? That's a totally new. How do we approach that? The governance of that? No, it's really difficult.
So.
Although I think if you're looking at lab data and all of those things when the patient comes in, and the Fitbit data says one thing and things don't look any better, I think that's, those conversations occur, right? That's
Right.
what you're talking about with the.
Well, and we should get the endocrinologist to help us with that, because everyone goes in and says their sugar was great and then their A1C is awful. And it's like, no, I prick my finger every day. I got a good number. Really? Oh, I left my glucometer at home. Right? I mean, this is a standard rap if you're in that business. You hear this every couple times a day. So let's shift gears a little. All right, as much as I might want to be monitored, as much as my kids might want the fitness part of it, as they're very athletic, the part of this that I'm most interested in is, what does the technology have to offer me in terms of trying to manage my elderly mother, trying to manage a sick family member, and monitoring, I think in general, has this wonderful opportunity to kind of create something that we all come together about, right? We're going to talk about how mom did this today, how she did this week. There was a fall. How does that get reported to the family? There was a bad reading, a bad result. How does that get reported to the family? How do we, begin to create kind of social support for using the data to improve health? Are any of you guys thinking about how do we bring families in? How do we position this out into social? I mean, the gamification is close, but in that vein.
Right. So we've done a lot of proxy access for our patient portal, which has been helpful for sons or daughters caring for other mothers, dads, etc. But there's limitations to that, and I don't know that we have enough. Speaking from the rehab standpoint, that we have enough anticipation of either activities of daily living or mobility decline. One of the things that we're doing with our comprehensive joint replacement is we're actually assessing the folks before they come in with regard to their activity levels and what where they are in that spectrum, to understand and project what they may need afterwards, or whether they should be delayed and go forward. And so, again, if we are engaging people and enrolling them in unique programs,
right.
We might want to give them and say, look, you got to get to 5,000 steps a day before you can get joint replacement, whether that's with a walker or a rollator, or you need to do it around the track or something. You need to show that you're actually being active, because we know that this predicts success afterwards.
Right.
So I think we maybe need to consider our prehab and looking at some of those motivating factors for their wellness. And I think you could engage families around that.
Right.
And also, I think the so-called multidisciplinary approaches to treating patients, grouping them in their diagnoses. So a heart failure specific clinic, our diabetes specific clinic, and how do you take care of the elderly, involve the families, get multiple disciplines around the pharmacist, the physician, the nurse. I think those are ways to try to monitor these patients and keep them well.
Right. Where should the data sit? Should this data really sit in an EHR? Is it that good? Does it need to sit in some affiliated system that we then have to do integration and analytics for?
Do I have to call IT every time?
I don't know. Again, I think this is the challenge, right? So does this demand its own application, its own set of rules, or are we better off trying to integrate this just like every other new technology in the existing process and
Well, what I'll say
treatment plan?
is that how did this blood sugars used to come in?
Right.
Oh, here, doc. Here's my sheet of paper.
Right.
Yeah, right.
I can't, what's this one? It's wet. It got red. What's this number? So, I mean, the blood pressure readings and the, blood sugar readings really did used to come in on scraps of paper. And so, at least if it is automatically uploaded and viewable in a meaningful way, I think that may be better.
Right.
And if it has, like we're doing the analytics, highs, lows, month, and ranges, I think that's probably better than scanning the sheet.
Right.
But I think we have to look at more inventive ways to do that and more cognitively in our workflow ways.
And I think the other big, I guess there was a meeting earlier, interoperability I think is very important in this. So patient shows up in the emergency room, what was their creatinine yesterday? What was their B-type nitrate peptide yesterday? How do I get that data? It was done over at the endocrinologist's office. It was done at the internist's office. I'm the cardiologist. I'm in the hospital. How do I get that data so that I can take action that is meaningful and not hurt the patient? I think that is a big part of how does all this data become actionable for all of us together. Yeah.
And that, I do think that actionable is a big deal. We talk all the time about actionable analytics because otherwise it's just a couple $1 million of storage sitting on the raised floor. All right, if you can't do something with the data, why store it to begin with? And you find that you're storing it for business reasons, for liability issues, for regulatory issues. Well, there's much better uses of the data. Let's do something proactive with it. I did want to ask, this is an area where there's so much new and so much cool. And I've seen a bunch of stuff. I think Robin had some great examples. I did want to give our panelists an opportunity to talk about, is there one really cool thing you've seen in the wearable space in the last few quarters that just really impressed you, that changed how you thought about the technology?
I think the thing that's affected lives the most from a cardiology perspective is the Life Vest. I don't know how many people are using that, but we've had patients going out, so they're pretty sick. They've never had a life-threatening event, but they're at risk of it, and they have a life vest, and they go into ventricular fibrillation and get shocked by their life vest, and it saves their life, and they come in and they get an implantable defibrillator. This has been a significant game changer, I think, in our world, because as you know, most of you know, we've been audited for the defibrillators we put in, right? So you can't put a defibrillator in within 40 days after an MI or 90 days after bypass or PCI. Well, you've got a person with ejection fraction 20%. What are you going to do with that patient? They're at risk of sudden cardiac death. And the Life Vest has made a significant, and I think as far as just saving lives, that's probably the thing that's been most impressive in our world. So.
Okay, I got to go rehab the chip in the brain to the external hand for the tetraplegic that they published this week. I think that was that's pretty hard.
Awesome.
Yeah, that's pretty hard to say that. I don't know if is it wearable if it's in you. Right?
Yeah.
Mobile.
Mobile. Right.
It's mobile.
It's mobile. But in looking at some of the things, we have a regenerative medicine and stem cell for ALS, and really looking at what will it mean to have some of those technologies, some of those type of treatment techniques in the future enhanced by ways that we can monitor or ways that we can detect better. There's a Brendan Spiegel at our institution does a lot of health services research, but he's developed it's a GI sensor that's overlay, and he's gotten FDA approval for that. And so again, we pretty much we've got all these other monitoring techniques, but our gut, we pretty much put our stethoscope on there and then we take it off. Right? How old school is this? So looking at that, we're looking at developing some of the similar sensors for swallowing dysfunction in stroke patients. So I think there's a whole host of technology that'll be coming that'll allow us to perhaps intercede, which is what anticipatory pieces. I think the cardiac world is far ahead of us in those areas.
Okay. And you know, predictive analytics are going to be interesting here. I think, so in the hardware business, there are some very expensive pieces of compute technology, and they're smart enough that they anticipate their own failures, and they call the service people for help. And the customer doesn't know there's a problem until the service person shows up. All right, and I started seeing computer hardware that would exhibit those behaviors in the early 90s. Well, now there are all kinds of devices that exhibit those behaviors, all right, airframes, all right, most aviation equipment is set up that way. GE has just announced an industrial product that many of you have probably heard of called Predix. Okay, Predix is a big analytics framework, and what you realize is that every piece of GE technology has embedded telemetry. All right, we all found out about this when the jet went missing in Asia. Okay, the engines were the only thing still talking to the rest of the world while that plane was flying. They're gathering that data, they're harvesting it, and they're trying to create actionable advice for their customers. And I see the same thing coming in health. And I think of the situation where, you know, the ambulance is going to show up in front of my house before I go into distress. And I do think we see the promise of that, you know, with some of these technologies, that the minute you understand something, you can begin to predict it. And you know, there is going to be this whole, think of it as a second or third generation around predictive analytics based on the wearables, and really not just the wearables. We're going to bring all this other data into, right? All the behavioral health data that people like Aetna and United have been selling to employers for years is now going to become available to us as we plug into this. Family data, all right? Data about lifestyle choices we've made, all right? I don't think it's beyond anyone's payer to pull in Facebook data if they can figure out a way to create a better predictive profile for you as a patient. So some of this stuff is fascinating, almost to the point of being scary. But I do think there's, you know, tremendous promise here if we can figure out the business model. So it sounds like two places to get started, right? We can immediately, as employers, begin to work with our employees. And this is a very straightforward program here because now we're focused on wellness. We're not trying to save the world. We're trying to make our employees more fit. What a wonderful thing. I mean, really, you know, what employee could object to that? We're creating a benefit, we're helping them, we're focused on their wellness. And think about what we're learning. We're learning how to manage the devices, we're learning how to manage the data, we're learning how to integrate this into our own processes and our own records. So a great place to get started. But where are we going to see the biggest impact? I think in some of these targeted applications in specific disease states where we can really make a huge difference, where we can affect mortality, where we can affect quality of life. So I mean, a fascinating market. My niece actually just went into this business because I told her it was going to boom for at least 20 years. So, and she is the newest, I think one of the newest research engineers at Medtronic. So, so I'm actually pretty excited she's gone into the space. I think there's tremendous promise here. But again, lots of challenges and really early days. Who owns it? Who pays for it? Who manages it? Who gets the benefit? It really is all up to us. So I think, you know, we have a few minutes for questions. Sorry, Nick, I'm about a minute early. But I wanted to make sure you had time, and if we want one more round, you might not. So, but really, I think we'd love to have some questions out of the audience. I know the panelists would love to have someone other than me poke them with questions. So please, raise your hand if you have one.
So is anybody concerned that a lot of this sounds like a letter from the Joint Commission? It's process, process, process. Nothing about outcome. We're going to do this, we're going to do that, we're going to do that, but we're not measuring outcomes at the end. 5 years ago, we gave 16,000 employees $100 and a Fitbit if they would have some blood work done and get weighed. Right. We've stopped giving out the Fitbits because nobody wants them anymore. They would like to have more than $100. We can't identify, actually that's not true, we can identify a benefit in a very small group of our employees, but as an overall benefit, we're spending more on our, you know, we're self-insured, I mean, like you are, and I'm not aware of any big organization that has done this, that has identified that there's an ROI at the end of 2 years, 5 years, or 10 years. So a lot of it, I think we're doing on faith, but it's time to start gathering some data and see what really works in this regard.
You're right, with our program, we're doing it, but we don't have outcome data. We have data, we have process data. We know their cholesterol may be better, their weights may be better, their sugar may be better. But we like to think that translates into better outcomes. But I don't know that anybody has done anything to tell you that it actually has, at least amongst their employees. I don't know if.
No, and I think we're relatively new at doing it, so we don't necessarily have outcome data similar to you. We've seen some evidence that some employees are doing better, hypertension's controlled, their A1Cs are dropping, things like that. But we don't know how long they'll sustain, right, that work. So that's still to be determined.
I do think it's a place to start the engagement discussions of health with the employees, though. And I think it does, there's a certain employer, niceties around it, but also that mutual respect of that this is something important for our workforce to have them committed and be healthy and stay healthy. So there may be, I agree with you that we should measure. In rehab we had a lot of that for a lot of years. We weren't measuring our outcomes, and that science has to be done in all, and it's complex. It's not, because there's also just not one factor.
Right.
They could have a new kid at home, and they're running around more, and they're losing weight, or So I think there's lots of different factors.
And there's other effects. So employee satisfaction usually improves patient satisfaction. So even if it didn't show outcome, if your patient satisfaction improves, probably worth it in the big picture. So I don't know what it's going to show, but that's important as well.
Fitbit is placebo, huh?
Yeah.
Hawthorne effect.
Yeah.
Hi, so fantastic panel. I took some notes, which I'm going to incorporate into a talk I'm doing on a 90-minute talk, so thank you for that. So quick thing, last week, an ER actually used a Fitbit to diagnose somebody and make an immediate critical decision on their life. It was something to do with some stroke data. So that right there is a big deal.
The amount of time that they had been in fibrillation, I believe. Rapid
Right.
ventricular
Yeah.
response.
Yeah.
Yep, so that was pretty exciting. But what I'm seeing in Silicon Valley, and I actually even started a company a couple years ago that launched in Asia doing this, there's a lot of startups being the platform. Everybody wants to be the platform for data integration. I don't think it's going to be one of the big hospital systems that comes out and figures out this problem. It's either going to be Apple, who is really gaining headway in this, or it's going to be one of the entrepreneurs, because platform technology is one of the 8 rules of innovation out of Google, right? And we're seeing a lot of that, and entrepreneurs just think differently, right? So we don't have the barriers to entry. We're like, oh, we can totally do this, and we end up getting it done, right? So I would say keep a good eye, especially on Apple, though.
Don't you think they'll do it with a clinic, though? A Cleveland or Mayo? Or
Probably, yes.
Because
I
you
mean,
kinda
I'm
need
seeing like big partnerships like University of Washington with GE or Mayo Clinic with some of the other big guys. Of course, IBM Watson is partnering with a lot of these big ones too. So I think that's where it is going to come. It's not going to come directly from the clinic. They're going to be in partnership.
partnership,
Right.
right?
If anything, yeah.
And Google's also working on standards and specific metrics in and around what meaningful measures would be, and so I know that they're working on that too.
Right.
Yeah.
Yeah, and the platform challenge is a hard one. I mean, you think about, so these are cloud analytics platforms. There's 2 views. Either it's someone we've never heard of, it's one of the 5 or 6 big guys that already owns that market, and obviously Apple, Amazon, Microsoft, the usual suspects there. Increasingly, we do see this as a JV space. All right, the tech guys don't understand the healthcare market. The healthcare guys don't understand how to build federated, high-scale networks of millions of devices. And I do think there's some really interesting opportunities here. And one of them is commercialization of IP into this space. So I mean, if you look at Mayo, they've commercialized a bunch of their cardiac algorithms. I'm sure that in large measure, that's because so much of this data is now available, and we're doing analytics on these patients. So if I can license a proven algorithmic approach, why wouldn't I do that versus figuring it out myself? And it is really interesting to see the tier 1 systems begin to put their brand on technology, and we're going to see that more and more.
Well, I think it comes up. I mean, we have a $75 million VC fund at
Right.
Cedars with Long Beach Memorial Nation Ventures, and we've launched our first cadre of health accelerators with Techstars at
Yep.
Cedars-Sinai. And so we have some device, but we also have some more different, like there's a disposable ENT camera for intubation with a cost of less than $75.
Right.
So it may change what happens in the field. I mean, I think there's a lot of innovation, and some of it's going to be with mundane things, and some of it's going to be with really revolutionary analytics and
Right.
platforms.
Right. Other questions? Yes, in the back, please.
I come from the CIO space, and looking at more practical things that the government is asking hospitals to prepare for is around meaningful use and the integration of non-clinical data with clinical data, and trying to get that Fitbit information, that physical therapy information into the hospital situation. Can you elaborate more on near-term stuff that CIOs have to deal with to integrate that data to make it more meaningful, and how you guys are looking at it for meeting that purposes?
Well, so I mean, we opened up our patient portal, or our ability to upload consumer devices to via Health Kit, to any of our folks that have a patient portal account. And I think there was angst that we sent in Epic. You have to actually send an order to each of those that your doctor wants to monitor you. To open up the account or something like that. And so there was angst among the doctors of like, oh my gosh, we're responsible for this. But the disclaimers on the top say, this is just for information. If there's something you're concerned about, call your doctor. I think that's what we're trying to do, establish the platform so we can then begin to talk with our providers about what they found helpful and not found helpful. For the person that was in the ED, if they had been uploading via their, the watch, via the Apple Watch every 15 minutes, we would have had it actually more discreet than the Fitbit. But so I think that investigating the platforms and what might be most useful for your providers would be the place that I would start, because I don't know what your population health or your care managers or chronic disease managers may be utilizing now, and you don't know about it. It's not in there. So I think that would be a great place to start.
Any other thoughts on that? I do think, this is a big issue around FDA versus non-FDA devices. This is kind of a minefield for the manufacturers. Kind of an early, very expensive failure in this business was a product by Intel called the Intel Home Health Guide. They did go out and do the FDA process, and then they found out that they were impacted in places like Massachusetts by things like sunshine laws. And now it's regarded as an FDA-approved device. It gets treated just like a pharmaceutical if you have laws around sales and physician engagement, around the selling of the device. And all of a sudden, Intel was limited to $50 per doc per year for a marketing budget. Pretty challenging. So, the FDA thing is a slippery slope. There's a reason that the early fitness guys focused on the non-FDA side of the market, because they can sell right off the rack at Best Buy. But the FDA kind of coming to play here and really, helping to clean up kind of what's the IBM term, the mud, the mostly useless data or mostly unclear data, is really going to be a big first step here. Any other questions? Nick, you have one last question for our panelists? You want me to take it? We have a few minutes. Yeah. Okay. So where do you guys hope this winds up? I mean, what do you think the right end for this is? Should we all be monitored? Should monitoring be something that a physician prescribes for a period of time? Is this a familial decision, a personal decision?
I think some of the issues around integrating it into the care plan are really integral, because without, we know the context of what monitoring or these measures may mean to us to give care,
Right.
but the patients and families may not.
Right.
And so just like when I, reinforce an exercise program, I have to go through the benefits of that several times before people understand that the home exercise program or the increased mobility that they're seeing with their shoulder, knee, ankle, whatever, all of those pieces can be meaningful as an outcome, but they may not be able to see the incremental change. So I think incorporating into a care plan and then identifying what has the most impact on outcomes. I think we haven't done the research, we don't know yet.
I think also, where's medicine going? Less invasive and predicting before, what you were talking about, predicting before you even get the problem. How can we do that, and how does that data help us do that? I'm calling patients now and said, hey, you got a shock from your defibrillator. Did you know that? I did. And I know before they do. So I think that's also a big part of it. Can we use this to predict what's going to happen in the future to some of our patients?
Yeah, it is funny how data changes the relationship. I'm sorry, Eileen.
No, that's okay. I also think that it's going to be helpful. I mean, I don't know that you had asked whether it should be everybody, and I'm not sure it should be everybody. I think as people work with their providers, and as you said, they incorporating the care plan, it may not be necessary to be in everybody's care plan, but I do think those people that are at risk, and then those people that are potential to be at risk, right? We always look at those people that are most severe, but we have the next group that are moving into that arena, and we have to start paying more attention to that group to try to prevent them from getting to there.
Yeah.
So I think that's another group to look at.
It is funny, to your point. So I bought my mother a fall detector because we had some suspicions that maybe she wasn't telling us that she was having problems. And so, of course, the day after I gave it to her, she fell, and I called her. I said, Mom, are you okay? She says, why are you calling me? I said, well, you fell down. I wanted to make sure you were okay. Oh, well, I'm going to stop wearing this. I don't want you to call me every time. I don't want it to tattle on me. And I'm like, Mom, I'm calling you because I'm worried about you. All you have to do is tell me you're okay, and I'll go away. I'm okay. Okay, great. But it's fascinating how that little device is changing the way we interact. Yes, please.
So when does this become Orwellian? George Orwell.
Right.
I mean, how much do we really want to have that drone sitting there monitoring whether we're having the fried chicken?
Yeah. Well, and that is, I mean, a decision we all have to make. All right, we could have a very invasive health system that would deliver better outcomes than the one we have now. Is that what we want?
I think though we're already there.
Yeah. Well.
I mean, I don't need to put a monitor on anything else on me to feel like I'm already in the Orwellian world.
You're being monitored.
We're all going to die. I mean, I hate to.
Oh no! You're absolutely
an
right.
uplifting note.
Right. No, and again, we had a great talk over lunch. I don't disagree with you at all. I really do not.
That's that last mile they're talking about, right?
Right,
Last
right. I mean, that part of this is how much is the patient comfortable with, and how much are they willing to participate here. But I do think, the average patient wants to wake up tomorrow and have another day. And the average patient would like to pay less for that. So I do think, there are tremendous market forces at work here that are really, I mean, almost any technology can be used for evil. But hopefully that won't drive this.
Right, and we are looking at, we have a study going on right now about activity monitoring and rheumatologic drugs, looking at the number of steps and the number of treatments and the number of days since their last infusion, and understanding those type of things. And there's also some good literature on depression and decreased activity, and understanding when people may be getting depressed and being more vegetative. So I think that there are some ways that we may be able to predict and monitor, again, if patients are engaged in and around these type of activities.
No, I read a great study actually on the flight out here about teenage schizophrenia, and they have tremendous work that really says there is a link to diet, to activity, and to substance abuse. And that if a teenager manifests those three behaviors, they're much more likely. Wow, I never knew that. And that's something that as a parent, I probably should know. So I think, we're going to find these causal links, these statistical relationships, these interesting trends in the data. And to the point made earlier, we're going to have to figure it out to decide which of the levers we push on to really change outcomes. But it is still very early days. But the promise is stunning here, as is, some of the dark side. And I don't disagree with you.
So we've got the great technology, but that doesn't necessarily mean that they're going to be compliant
Right.
either,
Right.
you know? So the kid in my neighborhood that went off his meds and started stabbing people, even if we had the ability to monitor him, would he allow that, you know? So that's,
Right.
you know, the location trackers on felons.
Yeah. Well, in a few years, he won't have a choice. The parents will hit him with an injectable, and they'll get the data. So, but again, I'm not making a decision about whether that's good or bad. I'm just saying that's the likely outcome of where the technology's going. And I really do believe in 20 years, we'll be deciding whether we monitor our children from birth, and that'll be a decision that you make with the OBGYN as part of your delivery plans. So there is a certain inevitability around this, and it's all a matter of what we do with it. Technology is. It's not good, it's not bad, it's not worthwhile or a waste of time. It's what we make of it. So I think, the more thought we put into it in the beginning, the less likely it is to be ugly at the end. All right. Well, thank you so much for our panelists.
Thank you, Scott, Steve, Eileen, and
Thanks, appreciate it.
Yeah,
Richard.
thank you so much.
Just letting everyone know the next session starts at